Well, good morning, everybody. My name is Pavlo Rapovic. I'm a neurologist here at the MS Clinic in Swedish, and I wanted to welcome you to our neurology grand rounds. We have the pleasure this morning of hearing from Dr. Andrew Solomon. Dr. Solomon is an associate professor and division chief of multiple sclerosis at the University of Vermont in Burlington. He's an investigator on numerous multiple sclerosis clinical trials, investigating the therapeutic and prognostic interventions. Some of those are local, some of them are multi-center. Dr. Solomon's been recognized nationally and internationally for his research on MS diagnosis that he will be telling us, speaking about today. His current work focuses on evaluation of novel imaging and laboratory markers for MS. He earned his medical degree from Mount Sinai School of Medicine in New York, where he participated in the Humanities and Medicine program and also graduated with distinction in research. He completed his internship in internal medicine and residency in neurology and fellowship in multiple sclerosis and neuroimmunology at Oregon Health and Science University and Portland VA Medical Center in Portland, Oregon. It is my pleasure to welcome Dr. Solomon this morning, and I look forward to his talk on central vein sign and paramagnetic rim.
Thank you for that kind introduction, and thank you all for having me. I'm excited to talk to you all today. I'm going to share my slides here, and I just want to ask somebody let me know that you can see these okay?
It looks good.
All right, here we go. Okay, so let me just hide the video here. There we go. Okay. So today we're going to talk about emerging MRI biomarkers for diagnosis of MS, particularly central vein sign and paramagnetic rims. Now, I'm going to move forward here. These are my disclosures. Okay. Trying to move my video. There we go. So I'm going to start here. So I'm going to talk a little bit about why we need some biomarkers. So this is George Schumacher. These pictures, he was actually chair at the University of Vermont here. He was the first neurologist in the state of Vermont. He and others at NIH got together and realized that we really needed a diagnostic criteria in the 60s, and his criteria was, along with others, was really the first widely accepted diagnostic criteria that established these concepts for how we diagnose MS today. Established that we need to first look for a syndrome typical of MS, optic neuritis, myelitis, maybe a brainstem syndrome, have objective evidence of a lesion. So this means you need to corroborate those symptoms with evidence of a lesion in the central nervous system. So some finding on neurologic exam or later revisions to our criteria, MRI, for instance. The idea of dissemination in space and time involving more than one area of the nervous system over time to reassure us that we are dealing with an ongoing disease process rather than a monophasic syndrome. And the idea of no better explanation, right? That we fulfill 1 through 4 here. And then even at that point, we think about the differential diagnosis and we don't have a better explanation. I like to highlight here that no better explanation has never meant if you have somebody in front of you and they have an abnormal MRI and some neurologic symptoms and you don't have a better explanation, it must be MS. It's quite the contrary. What that concept means is once you get through all of 1 through 4 down below there, you still need to make sure it's not something else, because something, for instance, like NMO can certainly present with a typical syndrome, objective evidence of a lesion and dissemination in space and time, but you may have some red flags suggesting a better explanation. This approach hasn't changed through our diagnostic criteria. Charlie Poser came up with a new criteria in the 80s that was widely adopted. He was also the chair here at UVM. But this incorporated paraclinical evidence like evoked potentials and CSF to help us diagnose MS sooner. And in 2001, as you all know, we included imaging after a lot of data by Barkov and others suggesting that we can use MRI to substitute for dissemination in space and time rather than waiting for a second clinical attack. And this sped up diagnosis even further, which is important because we've seen that the earlier we diagnose MS, the better people do in our therapies. But these elements that were established by Schumacher haven't changed. What's changed is really how we fulfill them. So as we've gone through revisions to diagnostic criteria over the years, what's primarily changed is how we meet dissemination in space and time. And then some of the disorders that we might recognize as a better explanation for MS have been better characterized, like NMO or MOGAD. But we still start with a typical syndrome with objective evidence of a lesion, and that hasn't changed. So this is my kind of overview of how I think about the diagnostic process. So somebody comes with symptoms, they have an abnormal MRI. We first, again, have to figure out if they have evidence of a syndrome typical for MS and a CNS lesion. We do our differential diagnosis. Then we apply the McDonald criteria. We think about dissemination, space, and time. They fulfill it, but we still make sure there's no better explanation, and we diagnose MS. What I like to highlight here is that McDonald criteria is not a screening tool in any way for diagnosis of MS. You can't just plug people into that. Neurologists are the screening tool. We have to decide if each of these elements are fulfilled. And McDonald criteria only works and performs with high sensitivity and specificity when all of these conditions are met. And these are clinical decisions, right? So there's all these validation studies, that come out after each revision to the McDonald criteria. This was in 2017. Obviously, I'm not going to go through some of these, but it works pretty well. It has high sensitivity and specificity. But there's still this problem of misdiagnosis. So we did this survey in 2012 of 122 MS specialists, and 95% had seen patients who had been incorrectly assigned a diagnosis of MS within the last year and had that diagnosis for a year longer. And people recalled seeing many such patients. We have some studies also looking at how frequent this is. So this was a study at UCLA and Cedars-Sinai, and almost 1 in 5 patients who had a diagnosis of MS established, not somebody who came for a question about diagnosis, didn't have MS. And we've had some other data recently. These are abstracts. It's not been peer reviewed, but in Spain, they looked through 1 year of referrals. People who came with a diagnosis of MS made somewhere else. It wasn't tentative. 13% didn't have MS. Argentina, 7 years of referrals, 16% didn't have MS who were diagnosed with MS. So something's not working. And this is not a new problem. When you look at Oliver Sacks's book on the move, he describes brain cutting sessions with residents and students. He remembers this occasion where they looked at 5 patients who'd been diagnosed with MS in life, and the brain cuttings revealed they didn't have MS, sadly. Similarly, probably the best study on how frequent this problem is from the 80s from Denmark, Danish MS registry over there on the right. These are postmortem studies in 518 consecutive patients with a diagnosis of MS during life, and 6% didn't have MS. Some of these patients obviously don't necessarily represent what we're seeing presently, because this was prior to using MRI for diagnosis. A lot of brain tumors had masqueraded as MS in this particular study. We had this study where we looked at a cohort of 110 patients who had been incorrectly diagnosed with MS, 23 MS specialists, 4 academic MS centers, and people were misdiagnosed for a really long time. You can see, 10 years or greater, a third. People were on disease-modifying therapy for MS, a third of them 10 years or greater, which is really, really devastating, not only for patients, but also their healthcare system. The cost of that is quite enormous. They were not receiving care for their correct diagnosis. A quarter of them were on a medication with a risk for PML, which, is a potentially fatal disorder. Quite concerning that patients are misdiagnosed. And most important thing down here at the bottom is that in 72% of those patients, there was an opportunity earlier to make the right diagnosis. And a third also suffered morbidity during this time, primarily in relation to the disease-modifying therapies they were receiving. Dr. Casey's study in California, this cohort of misdiagnosed patients are 43. Again, misdiagnosed on average 4 years, 60% were on disease-modifying therapy, 110 years of exposure to unnecessary disease-modifying therapy, which on average costs about $80,000 a year, unfortunately. Also, just emphasizing the risks of misdiagnosis. On the right, this was our cohort of 110 patients. Four of those patients participated in clinical trials for MS therapies. Unnecessary risk for those patients. On the other side, there was this case report of one of the first patients with PML in a clinical trial for this medication, natalizumab, and there was no MS found at autopsy if you look carefully at that case report. So what's going on? Well, essentially, there's some difficulty applying the McDonald criteria. So patients with atypical syndromes are diagnosed with MS, patients where there's no objective evidence of a lesion, patients where maybe the original provider seemed to misunderstand what juxtacortical and periventricular meant. And these are the critical elements of diagnosis of MS in the McDonald criteria. And these are from the cohort of 110 patients, and we looked at what were some of the causes. We also did a study recently that was published where we had MS specialists and residents complete this survey where we tested them on these components of the McDonald criteria and diagnosing MS. What's a typical syndrome? What's objective evidence? What's juxtacortical and periventricular? And suffice it to say, people didn't do as well as we thought they would. This was particularly surprising because we tested a lot of MS specialists as well. And there were a lot of misconceptions about what these terms meant or how to apply the McDonald criteria. So the McDonald criteria, has, all of these successive decisions along the way. Now, lastly, before we start talking about biomarkers, I also want to emphasize that patients who have MS also are misdiagnosed. So we have a lot of data that there's diagnostic delay before people receive their correct diagnosis of MS. So sort of the opposite of the patients I've been talking about. Unfortunately, a lot of that's administrative data or epidemiological data. So we don't have a lot of granular data on like why those patients are being misdiagnosed. And sometimes there's healthcare system barriers or other problems that prevent the correct diagnosis. There's misattribution of symptoms by maybe a primary care doctor rather than a neurologist. So it's a little bit hard to know what causes those problems, but on average, in a recent study in Norway, patients had a delay of 2 years for relapsing remitting MS from symptom onset to diagnosis, and up to 5 years for primary progressive MS. And this is really a problem because we know that early treatment impacts the disease course more robustly than treating people later. So the bottom line here is these are all clinical assessments that are susceptible to error. And having sort of a cascade of these assessments makes it even harder sometimes to do this right. So the question is, what if we had something here? Someone shows up with neurologic symptoms and an abnormal MRI, and what if we had a biomarker that was highly sensitive and specific for MS, right? So that's what I'm going to talk about. So I'm going to start here. This is Edward Rindfleisch. And in the 1860s, he pointed out or found, or I don't know if he quite discovered, but highlighted that there was a consistent location of a blood vessel at the center of MS plaques. He thought this was very interesting. He was a student of Virchow, who you may have heard of, but Charcot at the time sort of dismissed this. But this has come back over the years. In the 70s, there were some people who were looking at this. Tracy Putney at Columbia in the 30s and 40s, I believe, was looking at this finding and found it kind of interesting. So skipping ahead to 2011, a group at Nottingham in the UK, using 7 Tesla MRI, was able to see this finding in vivo, which was pretty cool. So if you look at A, this is a patient with MS, and you can see in their lesions, there's this dark center. And the patient B doesn't have MS, and you don't see this dark center. And you can see a sort of a dot as well as a perpendicular line, to that dot. And this is the central vein that Rindfleisch was seeing in MS lesions. And we've known for quite a long time that autopsy that many, if not all MS lesions have a vein in the middle. And we think this is where the egress of inflammatory cells happen and where the breakdown of the blood-brain barrier is in MS. Now, what was particularly remarkable about this study, it was a small study of 28 patients with MS and 17 without, was that if you had 40% or more of your lesions had this central vein, it was able to differentiate these groups quite well, as you can see here. And we've never really had anything like that in MS that was so sensitive and specific. Now, this is a small cross-sectional study on 7 Tesla MRI. They followed this up with a prospective study in 22 patients who they followed for a mean of 22 months. And again, here's some pictures of a central vein using this imaging approach. And again, 40% a threshold. So looking at every lesion, and we'll get back to that part, looking at every lesion for a vessel, you were able to separate these groups. And if you had more than 40%, it was 100% positive predictive value, negative predictive value for MS. So all 13 of the MS patients had greater than 40%, and all 9 of the non-MS had less than 40% of their lesions with a central vein. So this is really interesting, compelling. So very quickly, Dr. Reich and others, Dr. Satie at NIH, This is a nice demonstration of the translation of 7T MRI to 3T, and that things we could find on 7T for research purposes can be translated to 3T. So they created this sequence called flare star, which essentially is you see a flare on the left, and on the right you see a T2 star weighted image, and you kind of sandwich them together. And again, this is 3T. This is obtainable on routine 3T magnets, and you can see these nice central veins quite easily here in the middle. There's a couple more examples. Here's an infratentorial vessel, and here's some other patients with MS with central veins, and you can see them on different views. And you're really looking for this dot, and looking in the center, and then looking perpendicular to that to make sure you see a vessel transversing through the lesion. So quickly, there were a lot of cross-sectional studies. This was our study. This was, I think, 2015. I'm not going to go through this in too much detail, but we looked at 10 patients with MS, 10 with migraine with white matter abnormalities, and we used this sequence. And again, you could see here below patient with migraine, no central veins, or few, and on top MS. And the groups were separated pretty well. It wasn't perfect like in the other studies. And so that's okay. This is science, right? So we had a few patients with MS who had few central veins, and we had a few patients with migraine who did not have MS, who had a number of central veins. But again, this is still very, very sensitive and specific, small cohort. But the median percentage in MS was 84 and 22% in migraine. There were a number of other studies that followed this. This was a study in the UK. Here's some examples of their imaging. Again, small vessel ischemic disease and patients with MS. There were 25 patients with MS, 10 with small vessel ischemic disease using the sequence developed at NIH. And if you had a threshold of 45% or greater, there was 100% sensitivity and 80% specificity for MS. You could improve your specificity if you increase the threshold to 65%. By comparison, if you just looked at dissemination in space in these populations, this MRI dissemination in space, obviously that's not very specific. We know patients with migraine frequently have juxtacortical or periventricular lesions, for instance, or small vessel ischemic disease. So 40% specificity for if you just use dissemination in space. Also worth highlighting here that central vein seems to be related to the pathological process of MS. Dissemination in space is sort of like a heuristic approach. It's sort of a shortcut, but it's not very specific to MS. Worth mentioning, we've had some studies in progressive MS. These are patients with primary progressive MS and patients with relapsing MS and small vessel ischemic disease. And there was no statistically significant difference in the proportion of central veins in progressive versus relapsing MS. So suggesting the underlying disease process, at least in this aspect of the disease, is similar. The groups were quite separated from the small vessel ischemic disease again. Over this time in 2016, there was a consensus paper published. The hope here was to standardize what we're talking about. So what is a central vein? And I'm not going to go through all the criteria, but it was important to establish some rules. So, that we wanted to look at a lesion that was round, that was a certain threshold of size, at least 3 millimeters in diameter, and that you see the vein on two views perpendicularly to each other. The lesion runs, through the vein runs through the lesion, and so on. And we excluded, confluent lesions or lesions with multiple veins because it's kind of hard to find a center in those lesions. What's also important to mention is that there have been numerous attempts at looking at different sequences. So this T2 star EPI that I've mentioned that was developed at NIH for 3T central vein detection has been compared to other approaches. In this particular study, again, this approach allowed the highest proportion of central vein visualization in patients with MS. This is a cohort with 10 patients with MS and 10 with small vessel ischemic disease. And you could see the central veins with other approaches and other imaging techniques that show vessels, but this T2 star EPI seemed to perform the best. And we'll get back to that again in a minute. So we were really looking at, up until this point, like every single lesion for a central vein on these scans, right? And that's really time consuming, really, really burdensome. So there were attempts to look at just a few. So in this study by the group in Nottingham again, they're using the T2 star EPI now on the 3T MRI. So this was the group that initially published the 7T data. And they came up with this idea or rule. So if there's 6 lesions with central veins, it's MS. If there's fewer than 6, but there's more central vein lesions than non-central vein lesions, it's MS. And then if neither of those conditions are met, you know, you can't diagnose MS. And this is only 20 patients, but they used this approach, and it worked in 20 out of 20 scans, and it took less than 2 minutes. So basically, first they validated this. I'm sorry, first they tested this in half their cohort, and then they validated it in the other half. Again, small cohort, cross-sectional, but it worked. We did something even more simple in 10 patients with MS, so 10 patients with migraine, 10 who are misdiagnosed with MS, and then 20 patients with MS. There's some examples again of what these scans look like. This is migraine on the bottom and a misdiagnosed patient, and then here's some patients with MS on the top. And we just looked at 3. We said, we had 3 raters, and we said, can you find 3 lesions with a central vein? And we said, if it's 3 out of 3, if you can at least find 3, it's MS, or if you can at least find 2. And sorry, this is sensitivity and specificity, but we did pretty well with pretty good agreement in this study with 3 raters, just looking at 3, just trying to find 3 lesions with a central vein, which was pretty exciting. Now, I've talked about central vein and small vessel ischemic disease and migraine and primary progressive MS, but there are other disorders that can mimic MS where it can be very challenging, especially vasculopathies. And this is a very impressive study. I thought in 31 patients with inflammatory CNS vasculopathies and 52 with relapsing MS. And these are disorders like antiphospholipid antibody syndrome, lupus, Sjogren's, and primary angiitis of the CNS. And again, you can see this threshold worked, pretty well. So a 50% threshold was able to separate MS from the group. Again, if you 50% or more of your lesions have this central vein, it was MS. What was also important to highlight here, is that this like 6 lesion rule and this 3 lesion rule, they didn't work so well. I mean, they worked relatively well. I mean, so they had, you can see the sensitivity and specificity down here below where I've highlighted the 50% rule. But this study to me suggested that, especially if we're going to have more difficult patients in the mix, a threshold that involves looking at the total proportion of lesions with a central vein may be more accurate. Summing up a little bit, we have all these cross-sectional studies. This is a slide from Dr. Satie from 2019 that have looked at a variety of disorders that can mimic MS, so include NMO, Sussac's disease, small vessel disease, these vasculopathies. And throughout all of these cross-sectional studies, we've seen that this threshold of around 40 to 50% can separate these groups. So we've been able to replicate this. Now, the biggest central vein study that has been done was on behalf of Magnums. This was published just last year in 2019. I looked at 606 people. They had this very interesting blinding approach where everybody involved in rating got like I think it was a third or a sixth of the MRI as a cube and was able to rate that to try to eliminate bias. Because if you see some of the MRI and it kind of looks like MS, maybe you might find more central veins, for instance. So I looked at 4,000 lesions, and these are patients with MS, CIS, NMO, SLE, small vessel ischemic disease, migraine, cluster headache. And again, sorry, this is kind of small, but they found a 35% threshold had the maximal sensitivity and specificity. It wasn't quite as good as the others. Now, the issue here to highlight, even though this has been the largest study on central vein, is it used an approach, susceptibility weighted imaging, that is not what the NIH and others have been using. This was a retrospective study. So they found these 600 subjects in their research cohorts who had SWI imaging or SWI. And so this was retrospective. There were 30 people in this study who had received this optimized T2 star EPI sequence. And that was much more sensitive for central vein. Nevertheless, this study suggests that this is a reproducible approach that has a lot of promise. Moving forward, what we needed was some prospective data. So up until this point, we really just had studies involving people where we knew what they had, right? So you take people with a rare disorder or with MS, and you see how well central vein can differentiate them. The problem with that is, those patients may have had those disorders for a while. It may be more clear at that point in the stage of their disease what they have. And it doesn't really tell us if somebody shows up with a new symptom, a new diagnosis, diagnostic evaluation for the first time, how well central vein is going to predict what they have, right? So the cross-sectional data was reassuring, but we needed some prospective studies. So this is where I am here. So this is one of the first attempts on a 3T approach looking at central vein. So this is a small study. There were 35 patients who had received a clinical diagnosis by the end of the study. The median percentage of central veins was 51% MS and 28% non-MS. So again, here in this study, this is again the UK group, Dr. Evangelou and others. They found that there was 100% sensitivity and almost 75% specificity with this threshold of 40.7 lesions. So again, suggesting that this is a useful approach. And these are, and I haven't mentioned sensitivity and specificity for McDonald criteria, but these are definitely in the ballpark when used in perfect conditions, which is not always the case. This study was also pretty interesting and just came out recently as well. Pietro Maggi and others had 39 patients who had red flags. So they might have presented with a typical syndrome like optic neuritis or myelitis, but they had sort of red flags that might have suggested other syndromes. And they didn't have a diagnosis at the beginning of the study. But ultimately, 27 had MS and 12 had non-MS diagnoses that were lupus, sarcoidosis, migraine, Sjogren's, spastic paraparesis, NMO, and SUSAC. And the question was, if you got central vein at the beginning of this, could you have kind of facilitated diagnosis more quickly in these patients? The 40% cutoff, again, was associated with 97% accuracy, and 96% positive and 100% negative predictive value. And you can see the groups here. Again, we don't have something that's 100% yet, but this is pretty powerful for a biomarker, that we can separate these groups so well. So again, this is one of two studies that has shown us some predictive power for central vein. And these were prospective studies in patients who've been followed over years who presented where the diagnosis initially was not known. So this is encouraging. The last study that is very recent that I wanted to highlight is looking at vascular comorbidities. So you might wonder, if we're looking at a proportion of lesions with a central vein, what happens if you have a patient with MS who has hypertension or small vessel ischemic disease or migraine, and maybe accumulating lesions that are not MS lesions? Does it make it such that central vein doesn't work as a diagnostic biomarker? So in this study, they looked at vascular risk factors and age. And what you're seeing here on the left is the proportion of central perivenular lesions or lesions with central veins diminishes as people get older. And as you accumulate more vascular risk factors on the right, the proportion of lesions also diminishes. But what's also important is if you look on the left, all of these patients, with the exception of one or two, remained over the 40% threshold for central veins. So while while there are certainly changes over time and with other conditions, in these patients anyway, and I believe there were 50 patients, the central vein threshold of roughly 40–50% does still seem to be pretty specific and sensitive for MS in spite of comorbidities, which is an important study. So that was sort of a whirlwind tour through central vein. And what we really need is automated approaches. So, right, it's very burdensome to look at every lesion. And so there's been some progress here. And I won't go into these studies in detail, but there's been progress at Penn as well as at NIH looking at convolutional neural networks. And they've tested, sort of the computer against the human. And you can look down on the left here at the AUC for two approaches in the Penn study that I was fortunate to help with. It was quite good. So, we can teach a computer, hopefully eventually to see a lesion and determine if there's a black dot in the middle of it or going through it. Like, I think I have confidence we can do this. And there are approaches that are emerging. And the CVS Net article was published this year, but there have been tremendous advances even using that approach as well at NIH. So I think these will only get better. But they're time consuming to develop because you need a large data set to train on and validate on. But there will continue to be progress. So I'm hopeful that we can still look at this threshold in without these automated methods in the future, without the need for some poor postdoc or medical student to look at every lesion and count the vessels. Now, lastly, we need a multi-center prospective study, and we have one. So this study just started. This is part of what's called the North American Imaging and MS Cooperative. And there's 10 centers. There's going to be 400 patients who show up for a new evaluation for MS in this study. So it's funded by the NIH. And we're going to look at how well central vein predicts diagnosis of MS and how we can best integrate central vein into current McDonald criteria, if that's necessary, or maybe combining aspects of the McDonald criteria with central vein can improve specificity and sensitivity. We're going to look at also, obviously, how well central vein performs on its own. Our gold standard still has to be the McDonald criteria to validate it against. So this study is ongoing, and I'm hopeful in the next few years we'll have pretty definitive data from this study. The study is also looking at whether this T2 star EPI sequence is more, as we think, more sensitive and specific or more sensitive actually, for the central vein than traditional SWE or GRE imaging. There's been a number of studies that have suggested this, but there's a lot of studies that are still coming out of Europe and other regions where people are using this other approach because it's just more accessible. Now, I didn't mention, well, we'll get to the sort of sum this up here. So central vein sign potentially seems like a very highly specific and sensitive MRI biomarker for MS. That may help us. What's nice is it reflects the underlying pathophysiology of MS, right? So it's logical. We've seen now we can do this on 3 Tesla MRI, and there have been a number of studies now on 1.5 T also. We have this growing consensus on how to do this and what a central vein is. And through many studies now, this 40 and 50% threshold appears pretty optimal for sensitivity and specificity, thinking about MS. Now, there's, this is not the end. Like we still probably have more progress to make in diagnosis of MS, but this is, we have the most data for this biomarker than any that I've seen in decades in terms of promise. But there are problems with this. So somebody has 2 MS lesions, or 2 lesions on an MRI, calculating a threshold, proportional threshold, of lesions with central vein can be a problem. We are still limited to looking at round lesions. So there are patients who will show up who have periventricular lesions that maybe were initially discrete lesions that have kind of morphed into this like confluent white matter hyperintensity, where it's very hard to tell where the center is. Now, if you look at this image behind us here, there's a lot of vessels around the ventricle, and it's very easy to have a coincidental lesion with a vessel there from small vessel ischemic disease, for instance. So, you lose specificity if you don't have kind of a nice discrete ovoid lesion. So that's another limitation that will be there. We all see patients who have small punctate lesions or confluent lesions, and central vein might not work as well on those patients. Inter-rater reliability remains a bit of a problem. I didn't get into details. A number of these studies have tested that, and we do pretty well, but sometimes it's hard to see the vein. And we still need humans to train the machine algorithms. So we need to work on that as well. And lesion rating is still pretty time consuming. Now, I even mentioned sort of the method of kind of creating the sequence that you're seeing here in the background, but essentially you take a flare image, routine flare image, and this T2 star sequence, and they kind of get sandwiched on top of each other. But this involves post-processing. I know Philips, I'm not sure about other manufacturers, are working on this. I'm very interested in making this happen such that you can just have your scanner kind of create this for your PACS system, so you can just view it directly. But that's not possible right now. So, we have to do this after the scans are acquired and create the flare star sequence in order to look at central vein. You can look at the T2 star without the flare, but it's just a lot harder to see the lesions. So it's better to have them both together. But it's not a difficult process. It takes maybe a few minutes per scan to do the post-processing. You're basically like multiplying the images, combining them. So what do we need for central vein? Well, we need to finesse these automated techniques, and that process is ongoing. We're not sure if we need contrast or not. There's some recent data that we presented at ACTRIMS I think was presented at ECTRIMS also, suggesting that contrast does improve the ease with which you see central veins. So, we're trying to move away from using contrast in MS as much as we can, but you might need it for this approach to be as sensitive and specific. I'm not sure with automated approaches if we can make up for that. So we're looking at that. And certainly we need a big prospective multi-center study in patients undergoing evaluation for MS, and that's happening. So I'm pretty optimistic that this will be a tool that we can use with a lot of confidence in the future. It may take another 3 to 5 years to have even more compelling data. But even now, if you see somebody where there's a lot of central veins in their lesions, or a lot of lesions with central veins, it does suggest that it may be more likely MS than something else. Now, briefly, I'm going to talk about in the remaining time another approach that's related though. So you can acquire this on the same sequence. So I thought it'd be worth talking about. Now, central vein certainly has the best data in terms of our imaging approaches to differentiate MS from other disorders. So I'm going to switch gears a little bit, and there's been this data on something called chronic active lesions in MS that's been emerging really over the last decade. And there are these lesions where there's this microglial ring around the lesion, and the lesions tend to slowly expand. And they're very different than what we might see as like remyelinated plaques in MS or chronic inactive plaques. But about 30% of plaques at autopsy in progressive MS have these chronic lesions where it seems like there's chronic inflammation, is what I mean. Now, recently, a number of groups have been able to image this, and this is a 7T MRI, and you can see this dark rim around the lesion here. And this has been pretty exciting because it's maybe again an important biomarker and even an outcome measure for treatment interventions that we can use. So. And why I say that is because of studies like this. So this study was at the NIH, and this is a really interesting study. So if you look at lesion formation as they did on 7T MRI, you can see an A up above and a contrast enhancing lesion that's forming. You can see on the T2 star sequence, which was what we had just talked about, you can see that nice central vein through the lesion. And then on the phase data from that same sequence, you can see this rim that forms around this lesion. The lesion doesn't shrink, it stays the same size and even grows over time, over 18 months. Whereas on the bottom, you see another contrast enhancing lesion on the T2 MP range on top. And then again, on the T2 star magnitude, you can see that central vein as the lesion shrinks. And on the phase data, there's a rim, but it's transient. And at 18 months, you don't see the rim anymore. It's hypointense, the lesion, and it's smaller. So we're able to image this process. And what really also is important here in this study, having persistent rim lesions was highly associated with poor outcome. So patients were more disabled if they had these lesions with persistent rims. What Dr. Absinta also showed at NIH is that you can see these on 3T MRI. So on the bottom, this is phase data from the same sequence that we use to obtain central vein sign evaluation. So you can do this. You have to do some special processing to what's called unwrap the phase data. But you can see on the top image, this is a patient with MS with a rim, persistent rim around their lesion on 7T, and you can see these on 3T. This approach has been developed and refined over the last few years. This study was not published. This was just published 2 years ago. What's important again here, and when we looked this particular study, I looked at actually 3 studies at NIH. Identification of these rims was highly associated with disability in MS in patients who are alive in vivo. So these are no longer autopsy studies. So these patients who had more rims tended to have more disability. And what's also important here is if you look at the left, this was on 7T, lesions that did not have rims tended to shrink or stabilize over time, whereas lesions with these rims enlarged over time and got bigger. And again, these patients were more disabled over time as well. So where we're going with this is this study was just published this year in August. So this was a large study that looked at 329 patients with MS and 83 without MS. And they looked at these paramagnetic rim lesions to see if there was specificity to MS, and there was. So in this study, about 50% of the patients with MS had these paramagnetic rim lesions. Excuse me. So it's not going to be a very sensitive approach if only half the patients have these rims, but it may be specific. So only 7% of the non-MS cohort, again, it's a cross-sectional study, had rim lesions at all. One had HTLV associated spastic paraparesis, and then 5 had other inflammatory neurologic diseases like Susak's. Now, what's interesting here is they compared it to central vein. So if you had more than one paramagnetic rim lesion, the sensitivity, as we mentioned, was about 50%, but the specificity was quite good. It was 93%. Again, they also tested in this same cohort the central vein threshold, and that did better, right? So 99% sensitivity and 96% specificity. They looked at combined, but the problem here was sort of they used not either or, but they used and. So if you had greater than one paramagnetic rim lesion and greater than 40% of your lesions had central vein, the specificity was 99%, which was pretty amazing, right? Sensitivity was diminished because of inclusion of these rim lesions. So, you know, we really need to test different ways of looking at this, but, you know, their conclusion here is if you had suspected MS, but low frequency of paravenular lesions, it might be useful to look for these rims, or cases where you suspect non-MS, but you have more paravenular lesions than you would like, you know, looking for paramagnetic rims may be useful. So just to close off here, this part, we need automated approaches to look for these rims, and they're happening. So this was just published, I believe, a month or two ago. So there are these networks that are being developed to look for paramagnetic rim lesions in MS. Because again, it's time consuming to look at every lesion to look for a rim. These are sort of in their infancy. This is one called RimNet. There's another approach that is in peer review right now from University of Pennsylvania group. So I am confident that you know, we'll have some approaches to help us see these lesions more quickly for future studies. So kind of wrapping this part up here. So paramagnetic rims, you know, we think this may be highly specific for MS, but certainly not as sensitive as central vein. Again, seems to reflect something about the underlying pathophysiology of MS, which is again, always useful for a biomarker. Again, we can see this on 3T MRI, much like central vein. We don't have quite the same consensus on what a paramagnetic rim lesion is and how to best image it. Again, we talked about here how we use the 3T T2 star EPI sequence and the phase data from that to look at this, but there are other approaches that have been published, called QSM, and certainly susceptibility weighted imaging and GRE people have looked at this. But what's nice here is this can be evaluated, you know, using the same sequence that you use when you acquire central vein, which is, you know, about 4-minute sequence. And, you know, it may be something that we can use as an adjunct to improve on specificity, in particular, of central vein sign alone. Now, again, we have limitations. So MRIs with low lesion burden may not work out for this. Inter-rater reliability remains a problem, you know, because you're really looking for a dark rim that's darker than sort of the interior of the lesion, which is very subjective. And then we don't really know how to handle, like, there are patients where we see these rims, and, you know, we assume it's similar process of activated microglia that are around confluent lesions or part of a lesion, and how to count those becomes difficult. Is that one lesion? Is it two lesion? If it's this large branching confluent lesion, you have different areas of you know, sort of hypointense rims. How do and we think that's associated with disability and meaningful, how do we quantify that? That's a little bit more different or difficult compared to central vein. And again, this is time consuming. So we need more than in central vein, we need more of a consensus here on what a paramagnetic rim lesion is, how to count them, quantify them, best imaging approach. This is evolving though. These seem very important for MS in terms of representing chronic inflammation, and may be important for clinical trials and as an outcome in therapeutic interventions. But it may also help us with diagnosis. We need automated techniques, and we need a big study, much like the central vein study, to see how well these perform. And I'm hopeful, as a post hoc analysis in that 400 patient study, we'll have these sequences and we'll be able to look at this as well. So, all right, that was a whirlwind tour, and I'm glad we have time for questions. So right now, MS is still a clinical diagnosis, right? We have to go through this process and think about these elements that were, established by Schumacher and remain important for making our diagnosis. Right now, education on how to do this seems more important than ever, given what we're seeing in terms of misdiagnosis. A lot of cases of misdiagnosis, if we were pretty strict about how we applied the McDonald criteria and made sure that people understood it correctly, we could probably prevent. But there are cases where, it's difficult, no matter what. So I think, a biomarker is going to be really helpful. Right now, thinking about differential diagnosis and how we use the diagnostic criteria is what we've got. We need some biomarkers though, because we know that diagnostic delay is a problem in MS. And so if we had some of these imaging techniques when people first present with symptoms and it was part of their initial MRI, we might be able to facilitate earlier and more accurate diagnosis just from that initial time point. They show up with neurologic symptoms, their primary care doctor orders an MRI. This becomes part of it. It can really help us make a diagnosis earlier, I think, in the future. And certainly to prevent incorrect assignment of diagnosis of MS on people who don't have it. So I think these are promising approaches, and I think that more than other things out there, I mean, there are other approaches that are being tested. These two in particular seem very promising as potential biomarkers for MS in the future. And we do fortunately have one large study that's ongoing. And I do want to say I don't know if every patient is going to be amenable to these approaches, but it may be that some combination of these approaches is going to be really helpful, in patients in the future. We have somebody with symptoms there, and I didn't mention there are patients who have atypical symptoms for MS who have MS too, and those are patients who are very hard to diagnose. And so we may have patients who show up with symptoms with MS. With a concern for MS, with an abnormal MRI, where we can apply numerous approaches in some sort of screening fashion, one with high sensitivity to begin with, and one with more specificity as a second step to really narrow down the diagnosis. I think that's where we're headed, but maybe a few years. So I'm going to stop here and open this up to see if anybody has any questions. And thank you guys for having me.
Thank you, Andy. I hope you can hear me. Yeah?
Yes.
Good. Thanks again for giving us this overview of a very evolving and promising area of MS research, especially in this area of diagnosis that can be so thorny sometimes. While you were speaking, there were some questions that came up in the chat, so maybe I'll start with those. Emily Ho asked if these lesions have been seen in pediatric MS.
That's a good question. I have not seen those studies. I don't know. Yeah, I haven't. I suspect those studies have been done. And being an adult neurologist, I have like a literature search bias or something. But I haven't seen those studies. People have looked at radiologically isolated syndrome, G1O in Toronto in particular. So we have these patients who show up with, like a migraine or a headache and have an MRI that's concerning for MS, and some of them may simply have migraine, and some of them may have asymptomatic MS, or maybe the migraine's related and we don't know what to do. And so there have been abstracts at meetings in the last year looking at those patients, and the ones who had, other things that we might consider typical of demyelination, like spinal cord lesions and positive CSF and enhancing lesions. They did have a lot of central veins, and they had paramagnetic rim lesions as well. And these cohorts have been followed over time in some centers to try to figure out who develops MS, and it may be that these approaches help us with radiologically isolated syndrome as well. I wish I had more data on pediatric MS. I suspect there's been a study or two, but I haven't seen as many studies in that population. But it should be similar.
Is there a prognostic value to this? In other words, people with a greater percentage of CVS lesions, is there something that tells us about their outcomes, their course of MS in the future?
Yeah. So good question. So we haven't seen that with central vein yet. There are people who are looking at that more specifically, but haven't seen that. We really think that every lesion has a central vein. So when you look at autopsy studies, the limitation is our imaging. So the sensitivity of our imaging approaches. So even tiny lesions, at autopsy, you'll usually see a venule. So I don't know that it would necessarily correlate with phenotype or clinical outcomes more closely than lesion burden, for instance, right? Or something else. There are some studies looking at the width of the veins and other things related to central vein ongoing that may give us a clue of whether or not it's useful for prognostication. Paramagnetic rim lesions, however, are, as I've shown, is sort of the reverse. So central vein was identified as a potential diagnostic biomarker, and there's some studies also looking at whether or not it has prognostic importance. Paramagnetic rims were identified as a potential prognostic biomarker that seems to be sensitive and very specific to MS in recent studies. But the thrust of those studies has been looking at these rim lesions as associated with disability. I'm not sure yet how well people have been followed longitudinally. Looking at Dr. Bowen's question, in terms of predicting progression or something like that, we have seen more rim lesions in some studies in patients with progressive MS than relapsing MS proportionally. Like out of all their lesions, they have more rim lesions in some of these studies. So it may be something related to that phenotype and that process of progression related to neuroinflammation. The hope is that we can also incorporate this imaging in recent, I know Dr. Reich is working on this, on ongoing clinical trials of new therapeutic agents to see if, particularly in our progressive MS trials, if we're able to make these rims resolve or change something about the appearance of these rims, if that has, if we can do that, number one, and then if we could, if it has some prognostic importance, if it changes the outcome in those patients. So I think it's an emerging imaging outcome measure that we're going to be looking at. Overall, people with more rims are more disabled with MS. And how it's tied to progression is still not sure. So another question. I think there is something on GE as well. Dr. Sati is now at Cedars-Sinai, and he's a great person to ask about what the different vendors have. But I think that there are approaches now that he's helped develop with each vendor, would be my short answer. I'm not sure. I mean, I have to look it up, but Dr. Gaiten in Argentina has developed something called Swan Venule. And that may be the GE approach. I'm not sure. But there are, for every vendor, there's an approach. And Philips has kind of taken the lead in terms of interest in developing this in a way that we can make it very easy to clinically apply. Yeah. Any other questions about stuff?
What about spinal cord lesions? Do they also have central veins?
Yeah, I haven't seen much, looking at that. The brainstem lesions, there is a paper I've seen recently in peer review that, looking at some of Dr. Sati's work earlier, we do see them in the brainstem easily. I haven't seen a lot of cord imaging looking at this. Yeah, this is sort of the bottom line. We've seen them like high medullary lesions and such, but not spinal cord imaging as much. Yeah.
Great.
But you would suspect if you should see them. Yeah.
Thank you, Andy.
Sure.
I don't know if we have any more questions.
Other questions? It looks like there's one other question up top. I'm just looking.
Oh, I'm sorry. That's right.
Yeah.
From Mike. It's a little bit
Yeah.
long.
Yeah, let me look at that one. So question is, hopefully you guys can all see this. Might central vein changes over time also be related to white matter UBOs we see as people age, or small vessel disease that are attributed to hypertension and lipids? So in MS patients, there's an immune process, or in age-related changes, there's little or no immune response. So I think I'm getting this, but I'm not sure I get the question exactly, but maybe this answers it. So we think that the process of formation of those lesions due to small vessel disease is just different than MS lesions. And that's why we're seeing these venules. That's sort of the bottom line. And people like Darren Akuda have also looked at sort of the shape and morphology of lesions that are small vessel ischemic disease rather than MS lesions, or comparing them, and they're different. So that just the way that these lesions form around a venule just seems to distinguish them from the way the lesions form in migraine or small vessel disc changes. And I'm not sure I know enough about, how those lesions form. And maybe it's ischemic, and thrombotic in a way that is different than MS lesions. And that's why we don't see a vein. We will see patients who have a coincidental vein, that happens to be where that migranous lesion formed. And that's why this threshold is important, because if you have enough lesions, you will have some with a central vein with any disorder, because there's a lot of veins. Having a threshold that looks at the proportion, it seems to be the most accurate way to do this. Yeah. All right, so I'm going to encourage people, if you have any other questions after this, to email me. And if you're interested in getting in touch with any of these researchers, I can also connect you. My email is on the slides, but it's just my name. It's andrew.solomon@uvm.edu. And I'm happy to answer any other questions after this, and or connect you with people or send articles and such. And thank you all for having me.
Thank you, Andy, for making the time. It was a pleasure hosting you today.
Okay, take care.
Take care. Bye-bye.
Thanks for watching. Hit the subscribe button for more medical content.